from the American Academy of Pediatrics.
The United States is the only industrialized country without universally available paid family and medical leave.
New policy from the AAP aims to help families when they need it most.
The AAP recommends a federal program that provides at least 12 weeks of paid family and medical leave within a 1-year period to care for a new family member or a sick family member or one's own personal illness.
But first, it's December, and we have some pediatric pearls.
So needless to say, the reason I point out these articles in the commentary is, well, first of all, they're nothing to sneeze at. Get that? They're nothing to sneeze at. And they will definitely put you in the know.
These stories and more on Pediatrics On Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode by unwrapping the latest research from our favorite journal.
So, Joanna, who wakes up earliest in your house?
My kids are pretty expert worm catchers, but that honor goes to my oldest daughter, whose internal clock is set somewhere between 6 and 6:30 a.m., and the rest of us would happily sleep in.
Well, you know, I am usually the earliest riser in my own home. I try and watch the sun come up, and then it dawns on me.
Wait, why are we doing dad jokes and talking about who is first up? Oh, this is an episode of First Up. I get it.
Now you get it.
Where we talk about new and exciting articles in pediatrics. So who's joining us today?
Well, Joanna, thank you for always being so up on my dad jokes. It is time for First Up, and today we will talk with Dr. Louis First, Editor-in-Chief of Pediatrics and a self-proclaimed prince of puns. What time did you wake up this morning, Louis?
Early enough to make this podcast a special holiday edition.
Ooh.
In fact, on the month with all the holidays, I'd like to share with you articles of note that will improve the work that we do. Happy holidays, Joanna and David.
Happy holidays.
Yay,
Thank you
I feel
for
like we
that.
need jingle bells on that.
Well, Louis, now you know that I am not a morning person, so let's talk about falling asleep, particularly a phenomenon I can relate to as a breastfeeding mother, falling asleep while feeding your infant. Depending on the setting, that can pose a real hazard for a baby. Can you give us a wake-up call?
Well, I can. In fact, I stayed wide awake reading a study we have in the December issue of Pediatrics called Mothers Falling Asleep During Infant Feeding. And to set the stage, as you both know, and I hope many listeners do, 2 years ago, the AAP upgraded their safe sleep instructions for infants, came out with new recommendations, and sprinkled throughout those recommendations were please remind families not to fall asleep while they're feeding their infants. And what was also in those guidelines was if you actually may fall asleep, believe it or not, feed your baby in bed versus in a sofa, a couch, or a soft armchair, because that will increase the risk in those particular seating arrangements, that will increase the risk of sudden unexpected infant death much higher than if you put baby with you in bed. Should you fall asleep, you have a nice safe bed, hopefully with a flat, firm mattress, no soft bedding. And as soon as you wake up, move that baby to a safe, independent sleep space. So that's what we're supposed to do when we feed our infants. But as you pointed out, Joanna, many caregivers will fall asleep while feeding, but just how many? So with that in mind, Drs. Fern Hawk and Rachel Moon from the University of Virginia, and we know the good Dr. Moon from First Up on some of the other months that we do this segment of What's in Pediatrics, well, they and colleagues basically put together a study that used a cohort of mothers who had been in a randomized study that the authors had done, looking at the effect of text messaging on safe sleep, promoting safe sleep, or breastfeeding. They ran that for the first 2 months, and after 2 months with about 1,600 babies and mothers in their study, they then sent another survey, and this is where we get to this particular paper. They sent a survey to, it turned out to be about 1,250 mothers, saying, in the past 2 weeks, have you fallen asleep while feeding your baby? And so let me cut to the chase, because mothers responded and they said the following. First of all, about 28% of the 1,200 and some odd mothers said, yes, in the past 2 weeks, we have fallen asleep. And 80% plus said, we didn't plan to fall asleep, but it happened. Now, the good news is, if you're going to fall asleep, about 60% fell asleep in bed. The rest of them said, we fell asleep in chairs and sofas. That's not good. Even falling asleep in a bed is not good. In terms of what were families feeding on, as you might expect, the breastfeeding mothers were most likely to fall asleep. And the authors say that maybe it's because oxytocin is released when you breastfeed, and that has been associated with falling asleep. What I thought was really interesting was why are mothers choosing the sofa or the chair to fall asleep. And significantly different relative to the bed, they said, well, it's easier to stay awake in a chair or a sofa. Well, it wasn't for these particular mothers. Number two, they said they didn't want to disturb the person who was in the bed. They said that they wanted to avoid the bed, which they had heard was unsafe. And yes, the bed is not great for ghost sleeping. We know that. But when it comes to, should you think you're going to get sleepy, the bed is the best place to feed your baby because of that firm, flat surface and no soft bedding. And they also said they needed a little more reading light, and they fell asleep. So we have some work to do. I think it's important that we cannot go to sleep on the job and remember not only the ABCs of safe sleep, having babies sleep alone on their back in a crib or co-sleeper next to that bed. But we need to take more time to talk about telling families to do whatever they can to not fall asleep during infant feeding to increase that risk of sudden infant death syndrome. And this is a phenomenal article to browse through, or better yet, read. And by the way, speaking of browsing, why was the snowman browsing through the carrot bin at the grocery store this month?
Who knows?
Close. These are not going to be hard. He was picking his nose.
Oh.
You got half credit. You got half credit. But anyway, please, let's remember, falling asleep while feeding is not a good thing to do while feeding your baby. And let's try to prevent that from happening.
All right. Well, I'm going to pivot mainly from that snowman joke and mention that as a hospitalist, I spend a lot of my clinical time trying to figure out why babies and toddlers are having fevers. And urinary tract infections are always high on the list. I felt like we had a pretty good handle on how to diagnose them, but technology's always changing, and we're always getting newer data. So how confident should I feel when I write down that I have ruled out a urinary tract infection in a febrile baby?
Great question, David. So let's take a peek. At the subject of urinary tract infections. And in particular, we're going to look at pyuria and the ability to diagnose it. You talked about the new techniques to do it. I don't know about you, but back in the day when dinosaurs worked at children's hospitals, such as when I learned how to do pediatrics, pyuria was sort of, you see white cells, start some, get that culture and start some antibiotics. And that became to some extent a gold standard that may not be quite so gold, according to a study that came out from Dr. Nader Sheikh at the University of Pittsburgh and Children's Hospital of Pittsburgh and colleagues in regard to the accuracy, as you pointed out, of some of the screening tests for detecting pyuria and in turn diagnosing a UTI. So this was a study that basically involved about more than 4,000 children between the ages of 1 month to 36 months of age. These were infants and toddlers who had a fever and no source. They got bladder catheterization of the bladder, had urine culture sent, and then basically the investigators in 3 different children's hospitals tried 5 different methods to detect pyuria. The dipstick, counting the cells under a remember microscopes and hemocytometers? They could do that. They could use something that basically looks at the dipstick without you looking at the dipstick, which is called reflectance photometry. They could look at white cells using digital imaging with particle recognition. It sounds like we're doing a science fiction episode, and some flow cytometry. So they put all of those together and said, all right, can we pick up pyuria? Which is the most sensitive? And it turns out with all those 5 different ways, the sensitivity ranged between the high 70s to mid to low 80s. It was basically the same no matter what device. But most importantly, notice I said high 70s, low 80s, which meant basically of those 4,000 plus children, 407 had positive urine culture, defined as 50,000 colony-forming units per milliliter. They also tried it at 10,000, didn't get much difference. But most notably, 20% of those 400 culture-proven urinary tract infections had no pyuria in those devices. They didn't show white cells. So First thing is, well, maybe you're thinking these must have been contaminated specimens or asymptomatic bacteria, and they're just sort of living the dream. And it turns out that previous studies, and the authors point this out, had shown if you're worried in a catheterized specimen about a contaminated specimen, you're talking about a couple per 1,000 specimens. And if you're talking about asymptomatic bacteria in a catheterized specimen, that too is only a few out of 1,000 specimens. Here we had 20% never showed pyuria and grew 50,000 colony-forming units per ml of a bacterial infection. So should we be using pyuria as our definition for urinary tract infection with all the technology that's out there? Well, to answer that question, we got a commentary from Drs. Brian Becknell and Joshua Watson at Nationwide Children's Hospital in Columbus, Ohio, who said simply, no, we shouldn't be using pyuria. When you come out with a sensitivity of about 80%, we're missing things, and so we shouldn't do that. They recommend that we need to find, the elusive holy grail of how do we better diagnose a urinary tract infection besides white cells. However, the authors of the study do say that if you are worried about a baby, there's no focus of infection, the baby is febrile, then it's reasonable to talk with the family, do a little shared decision-making, and start antibiotics while you let the culture cook, and then stop the antibiotics a day or two later if the culture is negative. On the other hand, the commentary authors, Drs. Becknell and Watson, really hope that we're going to find some new technology that will help us better diagnose a urinary tract infection. And actually, Dr. Sheikh has had 2 previous papers in our journal, and his colleagues. One of them noted the fact, actually 8 years ago, that organisms such as Klebsiella, Enterococcus, Enterobacter, Citrobacter can appear without white cells. And guess what? In this particular study, those were the organisms that showed up without pyuria. And the other thing Dr. Sheikh told us about a year ago, and I did a first up on it with you, was that using ribosomal RNA sequencing and an inflammatory marker is a much more sensitive tool for detecting a urinary tract infection, and allowed us to set the level of an infection at 10,000 colony-forming units per ml. So we don't have that yet in many of our hospitals. We don't have ribosomal RNA sequencing. But the takeaway, and something to put on your sort of takeaway list, would be that just because there's not pyuria doesn't mean you can rule out a urinary tract infection. By the way, speaking of takeaway lists, at this time of year, what lists do children who don't know how to tie their shoes end up on?
We're not going to guess it.
Oh, of course. The naughty list. It's that time of year. The naughty list. Yeah. The naughty. I tried to tie this together between the dad joke and a really interesting article that all that is urinary tract infection is not pyuria.
Well, Louis, let's tie in another topic that we talked about on the podcast recently, RSV. We were discussing how we're excited to be able to be protecting infants from RSV this season, either by giving pregnant mothers the RSV vaccine or by administering nirsevimab to newborns. But both these interventions are expensive compared to some other vaccines we give. These measures are medically effective, but are they also cost effective?
Well, let's talk about that. Let's look at cost effectiveness to prevent RSV, what it is and what it's not. Snot. I'm sorry. I had to just get us into the...
You need a tissue, Louis?
I just had to get us into the mood to talk about cost effectiveness of 2 very important new products that have been approved by the FDA. So let me remind everybody that a year ago, the Advisory Committee on Immunization Practices looked at, as you pointed out, Joanna, the vaccine for those who are pregnant. And if a baby is born and a pregnant person did not get that vaccine, we have the monoclonal antibody nirsevimab. Both were approved in 2023, and they come at a high price. David, as you pointed out, these are hundreds of dollars for these particular treatments, and the question is it worth it? And so to make a decision and get approval from the Advisory Committee on Immunization Practices, which is made up of infectious disease and public health experts that feed to the Centers for Disease Control and Prevention, the CDC, and then feed from there to the FDA, you better make sure this is cost effective amongst many other things that go into making the decision of go, no go. And that's exactly what was done to make this decision. And the reason I'm bringing this up is in Pediatrics in the December issue, we have not one, but 2 articles that deal with the cost effectiveness, one for each of these products, the vaccine and the monoclonal antibody for infants by Dr. David Hutton and colleagues at the Department of Health Management and Policy and the School of Public Health at the University of Michigan. And the reason this is kind of neat to put these into pediatrics is these were the cost-effective analyses that went to the Advisory Committee on Immunization Practice. And it's almost like, how do you make the sausage? How do they do a cost-effective analysis? So listeners can really get a handle on what's happening here. And the way they do it, which I thought was really interesting, it's a series of modeling and simulations where you look at all the data on the vaccine and the monoclonal antibody, all the trials. You look at the epidemiology of RSV. You look at the morbidity and mortality of RSV. You look at the side effects of these products, and you put it together and you start modeling and try to find a sweet spot between the lowest cost and the highest cost. And you do this with a measurement that's called the incremental cost effectiveness ratio, which I'm going to make pretty simple. It's the difference in the numerator between what you have to pay to treat RSV and give palivizumab, for example, which was available for we had nirsevimab, or what you have to pay once you start this treatment, meaning paying for the monoclonal antibody or paying for the vaccine, divided by the difference in outcomes. Do we have more healthy infants and less beds occupied in a hospital because we've given the vaccine or we've given the monoclonal antibody versus what would happen if we didn't do it? And when the dust settles and they come to that sweet spot, the average cost effectiveness comes out to be $150 some odd thousand per a perfect year of health, meaning a baby who might have gotten RSV, caregivers who may have missed work. It's going to cost $150,000 for a year of perfect health. And you say, that seems pretty high. And well, you think about it, the cost of nirsevimab, depending on how you get it from vaccines for children or privately, is $400 to $500. So you can start to see costs going up. And so the question is it cost effective? And to answer that, we got a commentary from Dr. Sean O'Leary. Now, he's an infectious disease expert at Colorado Children's Hospital, also is he's our AAP liaison to the Advisory Committee on Immunization Practices. Dr. O'Leary is in the room where it happens. So he watched this be analyzed and raises the point in the commentary that one of the ways you decide if something is cost effective is the World Health Organization gives a guideline that any new innovation should be no more than 3 times the per capita gross domestic product of a country. And it turns out that both the vaccine and the monoclonal antibody fit well within that threshold. And in fact, if we are to lower the cost of the vaccine or the monoclonal antibody, well, that will basically lower that ratio and make these products even more cost effective. If we have sicker babies in hospitals, again, that would make the cost effectiveness even more efficient. On the other hand, if nobody gets RSV or they raise the cost of the vaccine, we would have a problem. And if you think about how we give these products, the vaccine is only given to pregnant persons between weeks 32 to 36 of pregnancy and only in RSV season between September and January. We're not giving it year-round because it wouldn't be cost-effective. It goes outside that ratio. And for nirsevimab, we're giving it to babies not through the first year of life, under 8 months of age in that first year that they're born, if the mothers didn't get the vaccine or the pregnant persons did not get the vaccine. And then we're giving it in the second year of life to those who are only high risk. Otherwise, because we have to give twice the dose of nirsevimab, the cost effectiveness would not be worth giving the vaccine except to those who are at high risk. So needless to say, the reason I point out these articles in the commentary is, well, first of all, they're nothing to sneeze at. I get that? They're nothing to sneeze at. And they will definitely put you in the know, when it comes to better understanding what cost effectiveness is all about, and also how fortunate we are to have these 2 products, which I think are going to be game changers in reducing the morbidity, the mortality, and the hospital occupation of so many babies with RSV that do raise healthcare costs. And speaking of cost, do you both know what Santa's tax status is this year?
No.
Oh. He's elf-employed. Well, as I wrap up first up for the month of December, I have to say, if words will not convince you how important it is to remind mothers not to fall asleep while feeding their babies, and certainly that pyuria is not the gold standard, and that the cost-effectiveness studies have been very helpful in getting new products such as a new vaccine and a monoclonal antibody to prevent RSV, maybe a closing song will. And so to wrap up and bring on the holidays, can I just close out with a little ditty to the tune of Jingle Bells. And
we were hoping you would
follows.
serenade us. Yes.
Here we go. Find some ways at holidays to give these articles a read. So when it comes to children's health, you truly take the lead. And so this year we give a cheer. We hope we've met your needs. We wish you happy holidays from everyone at Peds.
I wish I had
Pediatrics,
some
that
bells.
is.
Ding, 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 you know?
Have a peaceful holiday season and a joyous new year, both of you, and to all the listeners of Pediatrics on Call.
Lyrics and performance by Dr. Lewis First. Lewis, thank you for being with us today. And to read the articles we discussed today, go to aap.org/podcast.
Coming up, we'll look at ways paid family and medical leave can help businesses and employees.
We've talked on this podcast before about family leave. Specifically, we talked about parental leave and having kids in residency, but there are other reasons why work sometimes needs to take a back seat to family.
David, I am finding myself now in the sandwich generation, where I'm taking care of young kids and aging parents. And I find myself increasingly worried about my parents' health. So yes, there are more reasons than just babies that you may need to focus on family.
But you had a baby in the last year. And Joanna, I know that with your recent maternity leave, you got FMLA, but not all working parents are afforded that.
I did. I'm very privileged to have gotten it. And, you know, I actually did not qualify for FMLA in my first pregnancy almost 7 years ago, as I was just out of training and only at my job for less than a year. And it was so stressful. I wish there were ways we could better advocate for the time we need to take care of ourselves and our families here in this country.
Then you are going to love talking to our next guest. She is an author on the new policy statement on paid family and medical leave, Dr. Kimberly Montez. And back in 2022, she joined us on the National Conference and Exhibition plenary stage to talk about promoting health equity with paid leave policy.
Oh, wow. Dr. Montez. For our listeners, because she hasn't been on the podcast yet, she is an associate professor of pediatrics at the Wake Forest School of Medicine and is also the associate editor for diversity, equity, inclusion, and justice for the journal Pediatrics. Kimberly, welcome to the show.
Hi, Joanna and David. Thank you so much for having me. I'm so excited to talk about this topic. It is near and dear to my heart.
Now, I think many people know what paid family and medical leave means, but what does it look like in the United States today?
Great question, David. The United States is actually one of the only industrialized countries in the world to not have paid leave for parents. And so, as you mentioned, the FMLA, or the Family Medical Leave Act, is in place, but it provides 12 weeks of unpaid job protection. So no payment, but your job is protected for that specified amount of time. It entitles employees to be able to take that unpaid leave for specific family and medical reasons, and they're able to continue their group health insurance under the same conditions as if they had not taken leave. And as Joanna mentioned, there are lots of limitations to that law, including time worked, size of the company. And so over 50% of employees are actually not eligible for FMLA.
And if you don't have FMLA, what is there for you?
So if you don't have access to FMLA, there are a couple of options. If you've worked at a job long enough and you've saved up time, sick time, for example, or vacation days, you can take those. There are also other options that you can pay into, such as short-term disability. But once all of those avenues have been exhausted, you take that unpaid leave and your job may not be protected. In the United States, 1 in 4 women return back to work within 2 weeks. And that's actually my story. And I'm sure many of you have a similar story, either your own story or a patient's story. My daughter was born at 27 weeks, and I needed to prepare to take care of her. Unfortunately, the state that I lived in at the time and the company that I was working for at the time did not offer paid leave. So I had to cobble together combination of sick days, vacation days, and short-term disability in order to take time off. But she was in the NICU, and I knew I would need to take care of her after she was discharged, which she eventually was discharged with a G-tube and on oxygen. So I went back to work within 2 weeks so that I could save up more vacation time and sick time. I became one of those mothers who was unable to be at the bedside for her baby while in the NICU, even as a pediatrician, knowing how important it was to provide kangaroo care, participate in her cares and on rounds, read to her and sing to her. I was not able to do that because I did not have access to paid leave. Fast forward, I became really passionate about this topic because of my own personal experience and recognizing the privilege that I have as a pediatrician. Many of my patients don't have that job protection and that job safety. So I wanted to advocate, and it started off by writing an op-ed in my local newspaper. I asked my institution if I could use their affiliation when I signed the op-ed, but they did not provide that permission. Then I thought, ooh, the AAP will support me. I called the AAP and asked if I could use my AAP affiliation. And unfortunately, I was not able to because at the time, we did not have an official statement in support of paid family and medical leave. So right then and there, I made it my mission that I would help author a policy statement so that we could use it to lobby for a paid leave policy.
Wow, we're so glad you did. And we'd like to help. So I think when we advocate for paid family medical leave, people think that it's going to be short-term loss of an employee, and that's bad for companies, right? But you found through research and advocacy that allowing for paid medical and family leave actually boosts the morale and productivity of companies. How does that work?
Definitely, David. I think it's a really important point to bring up and to continue to say, because I do think there is a lot of misinformation out there about the benefits of paid leave to employees and businesses. So, for example, people really value being able to take time off from their job to tend to their personal needs. And so giving paid leave will really enable employees to be more engaged and to be more productive and not worry about that financial strain. For businesses, there are lots of benefits because it allows them to retain their talented employees. They're more likely to stay with the company than not come back after a leave. They're able to attract top candidates because they have this positive benefit they're able to provide. And it also increases productivity of the employees. So lots of really great benefits for employees and businesses.
And then let's look at it from another direction. What about the health of families? How does it benefit family health?
Great. Yes, it is beneficial for infants and children in many ways. So we know that, unfortunately, the infant mortality rate in our country is relatively high, and paid leave actually has been shown to reduce that infant and child mortality. It's also associated with lower rates of preterm birth and low birth weight. It is also associated with higher rates of vaccination, initiation of breastfeeding and breastfeeding rates, and it's also been shown to reduce child maltreatment. Those are the health benefits for infants and children, but now let me tell you about some of the benefits to parental health. So for maternal health, we know that studies have shown that paid family and medical leave reduces rehospitalization rates following a delivery. They also decrease postpartum depression rates, and they lead to better spousal relationships. So for example, the non-birthing spouse is much more likely to be involved and help with housework around the house, thereby improving the relationship and the bonding with that infant.
Well, we cannot talk about health and healthcare without talking about structural racism and discrimination because health inequities exist throughout our healthcare system because of those. How do they manifest in the accessibility of paid family and medical leave?
I mentioned that the infant mortality rate is quite high in our country, and actually it increased 3% from 2021 to 2022, which is the highest rate of increase in 20 years. We have one of the highest rates in the world, despite being an industrialized country. And in fact, the rate for Black infants is at least 2 times higher So that in itself is a structural inequity. But as you mentioned, even just the ability to access paid leave or even FMLA does vary by race and ethnicity and income status. So we know that because of the wealth gap and the income gap between genders and races, racial and ethnic minority individuals are more likely to work in low-income service line industries that are less likely to provide access to paid leave. And even when FMLA is available to one of those low-income workers or racial and ethnic minority individuals, they are unable to take unpaid leave.
And if we're talking about designing a federal program for paid family and medical leave, what would that look like in your vision?
Well, in our policy statement, the AAP recommends a federal program that provides at least 12 weeks of paid family and medical leave within a 1-year period to care for a new family member or a sick family member or one's own personal illness. So workers would earn a percentage of their monthly wages at a capped amount, and it would be independent of company size. And so that would look like potentially wage replacements. Specifically for low income, we recommend that it be progressive, somewhere closer to 80 to 100%. And expenses could potentially be funded through a national insurance program.
How can pediatricians help both themselves and their families access paid family and medical leave?
So for pediatricians who are caring for families who may benefit from FMLA or a paid leave policy that is in place through a state or a business, refer them to the resource and recommend that they talk to their human resources department to learn more about those benefits. On another level, pediatricians can be advocates for paid leave policies. So for example, pediatricians working within their own healthcare system can advocate that it provide a robust paid leave benefit for all their employees. When thinking about legislative advocacy, pediatricians can talk with their legislators using their patient stories or their own experiences to really lobby for a paid leave policy.
So, Dr. Montez, there is so much more that we could talk about on this topic, but are there any last takeaways that you'd like to leave our listeners with before they take leave and read your paper?
I like that, David. Yes, there is. We know that advocacy is a long game. Things do not change overnight. You heard my story. It's the power of one pediatrician. You can make a difference.
And I hope all pediatricians out there know that and are going to make some changes to paid family and medical leave. Dr. Kimberly Montez, thank you so much for joining us today.
Thank you both. It's been a pleasure.
To read the paper, Paid Family and Medical Leave Policy Statement, go to our website at aap.org/podcast. This week, instead of our say, we're sharing a special giving voice. This one involves two pediatricians.
At the 2024 AAP Advocacy Conference, Georgia-based doctors Keisha Frazier-Doe and Terry McFadden sat down to discuss the epidemic of gun violence and what drives their advocacy work.
Over the last 5 years, now that Congress has been funding firearm injury prevention, I think that is what inspires me. There's like a whole conference that's just dedicated to firearm-related research. And every year when I go to that conference, it's more and more and more people, and they all are very young and energized. So those are, I would say, just to kind of summarize in general, it's the people. It's the mobilized, excited people who are like, we're going to do this work that just kind of fills my cup.
So maybe we have reached the tipping point. I hope so.
I hope so.
Where enough people say, you know what, just because it's frequent doesn't mean it should be normal. We should never normalize the mass shootings, the one-on-one shootings, the kind of violence that is just ripping communities apart. And, as we kind of, this is where I guess we need to take a page from the book of these influencers who figured out how to get people's attention, whether they have evidence or not. But right? So I don't believe in science, but I believe in this guy over here who said this thing. Right. So somehow this guy over here who said this thing has figured out how to connect with people and share what they believe to be truth. So we've got to figure out.
We got to get our TikTok thing going on.
It's a TikTok. I don't know. If it's TikTok, I'm in trouble. But we definitely need to use some of the tricks in their bag to make, to try to get the word out and to change people's opinions and to galvanize people and to make them want to do something and to not accept that this is just our normal, because you wake up and it's like, okay, there was another mass shooting or there was another shooting in this community. And, rather than saying, oh man, there's nothing that can be done, we should all be fired up and saying, hey, we cannot accept this.
Yeah. This is not acceptable. This is not the world we want to live in.
No.
I do not want to live in a world where a 2 or 3-year-old gets a hold of a gun and shoots their sibling. We actually live in a state that has the highest amount of unintentional firearm injuries where children actually grab a gun and shoot themselves or someone else. I don't want to live in a state like that. And I know there is a way. I'm not moving out of the state, but I know there's a way to bring that number down, because I like us to be at the number one safest for children as opposed to number one unsafe. And so that's where I think kind of galvanizes me. I'm like, okay, so we're at the worst number. We're going to make this better. We can. All we can do, we're at the bottom. All we can do is go up to the best.
Right.
So I'm hoping that would be us for the future.
Thank you, Keisha Frazier-Doe and Terry McFadden, for giving us your voice.
The story was recorded in partnership with StoryCorps, a national nonprofit whose mission is to illuminate the humanity and possibility in us all, one story at a time. Learn more about StoryCorps Studios at storycorps.org/studios. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook, Instagram, and YouTube at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll hear a Pathways to Pediatrics from an early career pediatrician trying to change the workforce.
We'll talk to Dr. Chineza Ebo. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.